So interactive weaning in children, the question is, does it work? Well, when we're speaking about interactive triggered ventilation, two events are extremely important. One of them being the measurement of the event. It should be accurately measured of the respiratory drive with minimal artifacts from other sources, and an inspiratory phase that is initiated very accurately in its response to the patient's inspiratory drive. And what is very important is the measurement of the event, but also the synchronization. So when you look at patient-triggered ventilation, you would raise the question, is it really favorable? Well, you look at these different studies. In the early studies, you can see 93, 94, we could find results indicating us that patient-triggered ventilation was associated with decreased duration of weaning, decreased duration to extubation, and decreased incidence of complications like intraventricular bleeding and chronic lung disease. More recent publication didn't show any advantages, and looking at systematic review, there were some short advantages of patient-triggered ventilation and a potential usefulness in newborns. Now, when you look at synchronized or partially synchronized ventilation, you can see that a lot of modalities are used. You see the list here, and there is a real problem in pediatrics of terminology. Many of these modalities were actually not supported by large trials, and the question is there really, for infants, a global choice concerning synchronized or partially synchronized ventilation? We'll focus now on PRVC, or pressure-regulated volume-controlled ventilation. Now, PRVC is an interesting procedure. It's attractive in the philosophy of pediatric ventilation, since there is a theoretical advantage of having a guarantee about the tidal volume together with a pressure-limited aspect. It's a combination mode, a variable flow rate with a target-specific tidal volume. So that means that we all know that there are changes that can be rapid in lung compliance and resistance, reduction in high ventilatory peak pressure, and when we treat our patient where we want to improve the situation, we give them inhaled nitric oxide, we give them theophylline, surfactant. Well, we want to have an adaptation of the ventilation shortly after the treatment. So the question is, theoretically, this is interesting, but are there real advantages of using these type of modalities in pediatric ventilation? So I would like to highlight some of the studies that looked at PRVC. First one from 97 from Piotrowski showed it was a prospective randomized study, and they compared actually PRVC with time-cycled pressure-limited ventilation. They found equal duration of ventilation, but for the preterms with a birth weight of under 1,000 grams, there was a decreased duration of ventilation. A second study from COSIS, Pediatric Cardiology, 2001, was looking at children with post-surgery for congenital heart disease. And they were looking at the effect on cardiac output and ventilatory parameters. And changing from volume control to PRVC, and again from PRVC to volume control, they were able to demonstrate that there was a reversible decrease of the peak inspiratory pressure going from volume control to PRVC, and again from PRVC to volume control. What was very interesting and relevant for these patients, certainly, that there was no negative effect on the cardiac index, and there were actually no hemodynamic effects of the changes of these peak pressures. A study that we performed was comparing volume control, and PRVC. But the issue was not to look at the pressure, but to look at the assessment of analgesia and sedation related to the mode of ventilation. So we've put each patient on a volume-controlled ventilation, and they were switched to a PRVC and back again. Evaluation was blinded, and we did 108 measurements. Now, the assessment of the quality of analgesia and sedation was done by using the comfort score that you can see here, and that most of you will know, based on 8 items, all scored 1 to 5, meaning a high score is the patient that is extremely agitated, and a very low score is associated with a patient that might be over-sedated or too quiet. So shortly the results, you can see that just moving from volume control to PRVC, there was a significant change in the comfort score from 30.5 to 14.3, going from comparing volume control and PRVC. There was significant difference. On the other hand, in a second study, we also wanted to look at what would be the advantages in terms of analgesia and sedation, what would be the eventual decrease of needs that could be associated with changing the mode of ventilation. So the patient were changed from volume control to PRVC, and again, using the comfort score, we evaluated the quality of sedation and analgesia. And we could demonstrate that changing the mode of ventilation was associated, while maintaining the same comfort score, changing the mode was associated with a decrease of 17.2% of the cumulative dosages of these analgesia and sedation. So as a conclusion of this study, we found that under permanent administration of analgesia and sedation, the patients might be excessively or inadequately sedated according not only to the drugs that they receive, to the amount of drugs that they receive, but also according to the mode of ventilation. Now, a second point that I would like to address today is the switch from one mode to the other. What is the influence of the switch of one mode to the other on the ventilation and on back? Well, we see that several factors might influence the switch of the modes. You need a good trigger type, good signal, the choice of the mode. Well, when we switch from one mode to the other, it's a medical decision, so we need experience. And when you do this during the weaning period, well, it's a physician intervention. That's a very classical way of weaning a patient. But on the other hand, you can also have an automated weaning, which means that the software, the computer, the machine will decide when the weaning has to start. So when you would compare a manual classical switch to an automated or computerized switch, well, the manual switch is the one that we all learn to use, is based on experience, in some hospitals based on protocols, and ideally, the weaning should start as soon as possible, as soon as the patient is ready, going from controlled to supported ventilation, with a quick switch back, responsive to the patient needs. And what about the automated or computerized switch? Well, as soon as there is a triggering effort, well, the patient moves from a controlled to a supported ventilation, and as long as he is maintaining his efforts, well, he stays in supported ventilation, and there is no switch. In case the triggering would disappear, the patient could switch back, the machine will switch back to the controlled mode. So to see if this is working in children, we evaluate that in a number of children, and the inclusion criteria were patients in which we would expect spontaneous breathing efforts within the 24 hours. Randomization was towards manual switch, the classical way, experienced physicians, a protocol, and a manual switch back, versus an automated switch with an automated switch back. So what was chosen as ventilation parameters was PRVC, which switched to volume support, and in case of failure, switch back to PRVC again. We look at several efficacy parameters, time on ventilator, randomization, to switch, time to extubation, and the comfort score at extubation. And very shortly, I would like to share with you the main results that we found from this evaluation. Looking at the total duration of ventilation in the automated switch group and in the manual switch group, you can find that there was no difference in total duration of ventilation. But what was interesting is that the time from randomization to switch and the time from randomization to extubation, expressed in hours, was significantly lower in the automated switch group than in the manual classical switch, going from control to supported ventilation. And more surprisingly was the fact that the comfort score at extubation was lower in this group than in this group, indicating perhaps that the patient appreciated more the fact that there was a shorter time to weaning. A conclusion of this study was that there was shorter delay time to switch of the ventilation mode and shorter delay time to extubation and a better comfort score at extubation. So the differences can be due to the ventilator settings and were not caused by differences in the study population. We also observed a stable PaCO2 during the weaning period. We could say that the weaning was more comfortable and the extubation was performed earlier and associated with lower and better, I would say, comfort score. So as a conclusion of my presentation, I would like to say that question is, interactive ventilatory modes in pediatrics, are they really necessary? Well, I think that there are several arguments to answer positively, and I would say yes. It's optimizing the patient-ventilator synchrony, improving the comfort, and reducing the total duration of the weaning period and total duration from randomization. Now, the real difficulty in pediatric ventilation evaluation is that we need large randomized studies, and this is often a problem, and we need also these studies on different age groups, depending on the lung maturation and the age of these patients. I think that there is obviously a very definite trend towards increased sophistication of the ventilators, greater versatility, and I think that in the future, the new modes will improve ventilator management and interactivity. But you know, when you speak about the future, I always like to quote the words of Yogi Berra, who said, "It's difficult to make predictions, especially about the future." Thank you.